it really requires a lot more. Surgery cannot in isolation do a global health leader. Or infectious disease by themselves cannot create medicine in another place. You need everybody. That's how healthcare is provided. So if you look at this picture, there's surgeons, there's emergency medicine doctors, there's public health officers, and global health officers, anesthesiologists, and trauma surgeons, you name it. And so I just wanted to not only say thank you to all these collaborators, but I just wanted to let you know it is something that you cannot just only travel as a surgeon or as an anesthesiologist. You really need to think about all the ecosystem because you don't work in isolation where you are here, right? So you need everything around you. So quick definition, and you find a lot of different definitions about global health, but what is really important to know in this definition is, number one, it's really about improving health. Number two, it's about achieving equity. And the third piece is, this is worldwide. So when we talk about worldwide, we're not talking about just only Africa or Central America. We are talking about also really our backyard, right? Here, in the U.S., there's a lot of need that we need to think about. And so global health is about all people. And it's also the inner cities. And I just want to acknowledge, with that, for example, talking about our backyards and, in the South Dakotas or in the Minnesotas or the Wisconsins, I just want to acknowledge, for example, the work that is being done by the Gunderson Group, and I know Gunderson is here, and how they actually go out of their communities and provide care in remote communities, indigenous communities. And those are really important aspects of what public health and global health is about. The problems and the challenges are huge. Here is just a short list that can either encourage you to get going or discourage you to say, we can't solve this problem. This is really terrible. The couple of places where I've highlighted show you that we have about 6 million children who die under age 5. They die of all different causes. So when you think about public health and global health, you have to think about all the things that happens to children. And specifically, if you think about surgical problems, 250,000 die as neonates just because there is no surgical availability to fix the problems that could actually be cured or taken care of. The lower piece, the lower two elements are really very sad to see. Can you imagine you have about 1/3 of women worldwide have problems from partner violence. And think about the 5 billion people who have no basic surgical needs. So when they say basic, it's really as basic as can you drain an abscess? This person that's coming with an obstructed liver have a C-section and thereby you actually save 2 lives. I mean, when you say basic, it's really basic. Lack of basic medical care. So with those kind of issues, out of 7 billion people in the world, if we have 5 billion in this kind of desperate situations, I think we as surgeons, we need to wake up and be part of this fight. So a quick slide here to show you, how many people lives can be saved by having some basic surgical. And what's really interesting is to do these basic things, it's not really very expensive. And just to give you a perspective, this is from 2013. This is the U.S. military budget, and I think now probably it's what, $1 trillion. And to give you even more into perspective, our healthcare expenditure is, so it's really a drop in the pocket, but in the bucket. But sometimes things get so politicized about AIDS, which is the other piece that I will talk to you about in a little bit. But but most importantly, as surgeons, you should know what we do in surgery, particularly taking care of some basic, fundamental emergency and basic surgical care, has actually a benefit-cost ratio of 10 to 1. So it is critical for us, therefore, to think about what we do, what we teach, what we provide as surgical care is beneficial. It's probably similar to the polio vaccine. So this is really, what it's all about. At the end of the day, if we want to talk about health and don't talk about poverty, we are not going to really be on the same page. This is the curse that we have, and this is the biggest problem that we have worldwide in many places. And as you all know, poverty is linked with poor health. And so it actually continues to fester the cycle of badness in health. And the economic and political structures that sustain poverty and discrimination need to be transformed, needs to be changed. So we really don't pay attention to that. But the rest of the world is really in that cycle of poverty because we, who are in these rich countries, don't think about all these other issues to be connected. And so that's one of the things maybe we need to pay attention to. We should really not just simply say, oh, this is their problem. They are not having a good leader. They are not choosing. No, it's not. We are all connected. The world is 10 hours away from wherever you are by plane, and every economy these days is connected. So we cannot disconnect ourselves from the rest of the world by saying this is their problem or my problem. But what is really sad and problematic is we know where these issues are. And we know there are millions of people who live less than $2 a day, and we cannot expect there's going to be a good health care there. And what is interesting is what they call the 2030 Agenda for Sustainable Development. All the United Nations countries have come up with 17 goals that they want to achieve by 2030. And out of the 17 goals, the number one goal they have identified is really ending poverty. So we are talking about extreme poverty affecting hundreds of millions of people, extreme being less than $2 a day. And guess what? Over the past 2 years, because of COVID, we have probably about 20 or 40 million people more that have gone into that extreme poverty. And so poverty is the biggest challenge that in healthcare we should talk about, and the same happens here, right? Poor and marginalized patients who have to choose between the medical care and feeding their child. So it is a universal problem. It's not only a developing country problem. And we also know that charity cannot end poverty, or aid can never end poverty. You will always stay dependent. And unfortunately, that is a cycle of where low-income countries are right now. And so this gives me a chance to talk about a little bit about aid, because unless we know about how to help somebody, we cannot really create a system where we can solve problems. And this world is really the biggest problem that we have right now. And for those who love to read books, this is probably one of those books that you should read about aid, and tells you how actually, it's not helping. It's actually creating more problems. It is creating more dependency. It has removed, as it says here, the link of accountability between politicians and the population. You look at money or support that's provided to different countries, and it usually goes and plays in the hands of the politicians. And so we have to change it. Otherwise, the way it has been working for many years, meaning, there's more and more and more money that goes into it. But is it solving the problem? No, it's not. In fact, if you look what's going on over the past, 30 years, or since Second World War, there is more and more countries that are basically becoming dependent. And 7 out of 10 Africans are on the border of poverty, or extreme poverty. Mortalities for mothers and child are going up. And Africa is the most aided, but still continues to have the GDP falling. And so that policy is not really working and it needs to be changed. It's not like there is no knowledge as to, or people are not, or the politicians or whoever is making the policies, they do understand how you can really make actually change, because it has happened. Think about the World War II and its disaster in the European countries. In the Marshall Plan, what they did was, it was a major aid, a major help, but what it spent its dollars was on infrastructure. And the infrastructure building is what then got actually Europe to come out of. But if you, on the other hand, you go to African countries, start feeding the farmers, and you take all that initial, or put in all the surplus grain from China or Europe or America that is provided as help, and you overwhelm their markets and kill their markets, actually, you're not going to help them. But you probably would help your own farmers because you are taking away and buying their surplus products. So you see the twist there, and so people are not really in tune to really registering those things. And in fact, it's not lack of knowledge, but it is just, I think, total carelessness. If rich countries really think about it, they can focus on infrastructure development and building. The health and well-being piece is the other area of the development plan. There is really huge goals and targets, like we want universal health coverage for everybody, and so on and so forth. But when you go to places, these are pathologies you find. This is not curable. As a surgeon, I can go there and I cannot do anything about this, sarcoma in the thigh in a 24-year-old with metastasis, and I don't know what this huge neck mass might be, or it's so depressing to see a 19-year-old. I don't know how they survive, but it's an extra for the bladder, for example. But there are a lot of things, however, we can do, but we need to think about, when we do this, our global health activities in surgery, we need to think about what makes sense, what is sustainable. It's not really tackling these problems here, but it's really creating the infrastructure to train, develop their surgeons, their medical professionals, and help build some of their facilities in a sustainable way. So it's really, the thinking has to change. And one of the biggest problems, and I am just definitely part of this drain, if you will, is that rich countries in general are actually very dependent on individuals who are trained and have learned in the developing countries. And if you look in the US, we have like 1/3 of the medical force, physician workforce, actually comes from the developing countries. I'm not saying people should not come, but I'm saying there needs to, at some point, have some ethical discussions about how can we make this equitable? How can we help those countries who are breeding these individuals to really catch up with what they need? In fact, the WHO is saying more than material resource issues, human resource issues is the #1 issue. And when you look at those numbers, there is about 25% of the surgical burden, say, in Africa, but the 3% workforce is in Africa, whereas completely the reverse is true in the Americas. You have 10% of the burden, but you have over 30% of the workforce. And so these inequities are really actually a big issue, and as global health officers, as global health managers and individuals, those are the things we have to think about when we try to find solutions. Education is the other piece. Unless we think about education, and when I go to this different countries in Africa, I really want to pay attention to this. Education can be at all levels. It can be at the level of elementary schools, high schools, middle schools, but even when you go up the ladder, actually, it gets even worse, particularly for women. You go into the surgical field. If you go into this called COSEXA region, which is in the eastern part of Africa, that has 14 countries consortium. Out of the 2,000 surgeons or 2,500 surgeons they have, only 5% are women. Whereas in the population, 50% are women. And so how are you going to increase the number of surgeons or medical professionals if you are not paying attention to the gender gap that's out there? And so figuring out, thinking about this holistically is really what makes sense. So we cannot therefore just think about mission, or we cannot just simply think about, let's go and do this week 100 operations and come back. We need to think about this holistically. We need to think about all these different aspects that are an issue and a big problem. So with that, I just want to be mindful about the time as well, but just want to tell you quickly how I just got into this global health issues, because sometime in my second year of work at the University of Wisconsin, a patient of mine gave me this book and said, he knew already and where I come from, how I came here, and all that stuff, because we have actually bonded somehow over a longer period of time. As you all know, vascular patients are usually repeat offenders, we call them, right? They come back again and again and again. So we have really this good personal relationships, and he knew a lot about me. And so when he came with this, he was trying to challenge me by saying, okay, big doctor, you are successful, but what are you doing that has some significance? And he actually directed me a little bit towards the global health and about what I can do back home. And it was very inspirational, actually. And we had some dinners with this patient as well. And he worked for Hyper International, as you know. He was already involved in a lot of public health and international work himself. So my initial attempt was definitely to get going with surgery. And what I want to do was, in the next maybe 5 minutes or so, share with you my initial experience and what I learned from that, so that you could really maybe take that also if there are any one of you who are at the beginning of trying to do global health work. But what I learned with my initial attempt was, you can see here, Department of Surgery, University of Wisconsin, 3 surgeons from Ethiopia. I had a plan for them. Because cancer was a big problem. There was no laparoscopy. Everybody had an open gallbladder surgery. And then trauma was a problem. So a lot of people died. Trauma care was basically non-existent. So I had missions for all 3 of these guys, and with the money Delilan gave me, I brought them and they stayed with us for 12 weeks. They did all the rotations, so tumor board, trauma, emergency department, ICU, and skills lab, and so on and so forth. And so they, were just really getting them ready to go and start their units to get this. But 6 months later, I did not hear from them. They went, it was silent. And I just couldn't understand. Here we are trying to help them, and they spent 3 months with us, and they go, none of the work was done. None of our plans that we discussed were done. So when I reached back to them, and I said, what happened? What did I do? Why is this not working? So the first thing they told me was, Gurma, that was your plan. We were really not part of the plan, and it's very hard for us to come and become a cancer surgeon, or the other one to be a trauma surgeon, and the other one to be a laparoscopic surgeon. And I had to really take my pride back, think about this, and think about, okay, so I need to understand the priorities. What is it that they need? And not only that, not only that, but I have to think about, okay, if we start something, how are we going to develop that goal that is shared? And so we have to go back to our drawing board with them, so that we can reflect the priorities. Well, we needed to really focus on training individuals or surgeons. We needed to think about what is the benefit to you and what is the benefit to me or to my institution, because that was actually a very clear discussion where that mutual benefit was actually giving us that bondage in a much stronger manner. And so we had to redraw the whole narrative and discussion. It's not me showing you what to do, it's actually me also benefiting from this. And that was not very clear and apparent for me at the beginning, but it did become. So once that was clear, I mean, the rest is really history, as they say, because we included a lot of things. We did decisions together, and we involved our institutions, because, Gurma can move from one place to the other, but the institution is not going to move. So I need to really institutionalize this, right? And we need to have dedication to one another to make this a long-term relationship. So once we did this, actually, we were able to achieve a whole bunch of things in a few years. In a place where there was no emergency medicine services and department, we created actually not only an adult, but there was also pediatrics emergency services. We started a residency program. Actually now when I go, the residents who are in the emergency department don't even know Wisconsin was involved in this. It is so much removed, and they are so self-sufficient that I have weaned myself off. Actually, we have weaned ourselves off, which is the best way to end this, right? And other things. And so the message here is, we are not, going into this really only to help, but we are going there because there are things we also are benefiting out of. We need to have a clear understanding of that. We need to discuss that openly and create an environment where it is going to be mutually beneficial and mutually supportive for the programs, whatever we create. The last piece here, people think about, vascular surgery, that's complex. Why? There is no need in Africa. But what happened was, when we sent a student a few years ago to spend time in the diabetic center and do some basic preliminary screening for prevalent study of peripheral vascular disease, 11% of the patients in that clinic, granted it's a diabetic clinic, so high prevalent, 11% of them have some indication that they have critical limb ischemia, meaning they are going to lose their leg in a year's time. So it is everywhere. Diabetes is everywhere. Cholesterol is everywhere. High blood pressure is everywhere. Cardiac disease is everywhere. And so this vascular fellowship is actually one of the pride of our division. We are probably the only division in the country that has supported a vascular surgery fellowship program in Africa. And now they are self-sufficient really. So we go there because we want our residents to have some attachments there. And so in all areas, I think There is so much collaboration to do. So Saidal, if you can give me a few more minutes, I have just a couple of slides to talk about the work I do with the American College of Surgeons, because it really involves everybody. And as I mentioned earlier, global health is really a team sport. So we have to actually come together to build what we need to build. And the college, as you all know, has been there for 100+ years and has a lot of international work that the college has been doing. Operation Giving Back is probably the latest one in terms of international outreach, but this is also meant domestic outreach. We do several things. Here is the highlight of what we do is actually honoring and promoting individuals who have dedicated a significant amount of time. But most importantly, Operation Giving Back serves as a resource for people or members who want to provide volunteerism or dedicate themselves for humanitarian work. So that's what we do. And when we did surveys of our fellow members, this was a few years ago now, look at all the places they go. The larger the front, the bigger the number of people that go there. But a lot of times these are either individuals, it's individual institutions, or it is working for an NGO. So in other words, these are all activities that are so disjointed. Actually, sometimes you may find from one institution people going to same areas or same places, but they may not have even talked to one another. So what we do in this kind of a disjointed, discoordinated manner is actually we become burdened. We go to these low resource places, actually we wipe out the resources, because once they know there is 10 surgeons coming in, in 2 weeks, everything stops, because they have to take care of the guests who are coming to do some really good work. But I can tell you, because of that, there is also dysfunction that happens in those really overall, or those places can be overwhelmed. There's this week this mission trip, in 3 weeks there's another mission trip, and in 4 weeks, so there is actually fatigue, and it's really hard for them to maintain that. But we don't realize, because we go with a good heart. We go there because we want to take care of the 10, the 20, the 30 people who may have hernias, who may have goiters, who may have some other surgically fixable things. But we really strain their system. So we need to be very cognizant about that. So with that in mind, it was very clear and evident that we work in silos. Everybody is in the separate areas. And so our goal in Operation Giving Back was, how can we create a system where we can bring all these different bodies that are working in so many different areas disjointly together, so that we can create a situation where we go and do something really good, we'll really feel good about it as well, but can we create something that is really sustainable, long-lasting, and we can all be happy about? So with that in mind, we wanted to kind of get a conceptual idea about, can we create in this strategically in some places where it can be a training site, where we could really bring expertise on an ongoing basis to continuously and impact a region, actually, that's a place. Can we bring some subspecialties to this? Can we get the US global surgery programs of all these different departments together, so that in one area we can have actually a continuous presence, rather than going there for a month and then 11 months you're not going to be there, and guess what? When you go back after a year, everything is back to square zero. So with that, we had our pilot attempt that we did, and we identified a place. It happened to be in the southern part of Ethiopia, that you can see 13 US institutions actually agreed to partner. and each institution was going to be taking responsibility for 1 month, which gave us therefore a chance to build infrastructure at this site where people are going to be there for the whole year. And it's really, really worked well. In 1 year, we achieved so much that it's just incredible. The list is actually much longer than this, because there was now different groups. The work that is being done or started by one will be finished by another one, and so on and so forth. And so to the point where we have now, at the point where we have started our second hub, which is in the southern part of Africa, which is in Zambia, in Lusaka. And the third one is also under development in Rwanda, Kigali. And so with this, 3 places, we are going to cover all that northern part, southern part, and the middle part of Eastern Africa. And that way we can really create the learning hubs or learning centers where regional countries from all that area residents could come for any specific skills. For example, we are going to start ATLS training in Hawassa this coming year. That's going to be an ATLS training site. It will be very easy to bring residents and trainees from, I'm talking about ATLS, but when you talk about ATLS, there's all the trauma system thing around it. You talk about dispatch center and pre-hospital care and pre-hospital protocols. All that is happening as we speak. Then it's really easy to teach individuals from all the different or close by countries to come and learn. So for all surgeons here who are willing and interested and want to participate, please reach out to me, and I'll be happy to find you a chance. So whenever I go, so this is a picture from Ethiopia, and you can see these kids. And kids without shoes, clothes. It's the same story everywhere in Africa, wherever you go. And it really pains me, because I was exactly the same early in the 1970s, and you can see one of those kids where was me. Sorry. It's hard to talk about these things without emotions. So what I'm saying is there is hope. And that hope is going to come if we really, really think this as a problem of providing opportunities and providing opportunities for education. And I know these kids can do well if they can have education, if they can have an opportunity to finish even a basic elementary education. So with that, I really do think we need to ask ourselves, what do we do for others? And it doesn't have to be Africa. It can be here in our inner cities. And I just want to finish this by putting out this picture of me and my wonderful wife, that without her help and support and the rest of my family support, I would not be where I am now. I just want to say thank you to her. And I really want to thank everybody for listening to me, and Mr. Saido, thank you for this gracious invitation and giving me the pleasure. Thank you.
Nirma, that was absolutely outstanding, and thanks for bringing that all together for us. My question is there any relationship between you and many of the surgical programs and the Gates Foundation. And I was wondering, the Gates Foundation that has been so active in Africa, and wonder what they're doing, which seems to emphasize infrastructure, for example, building sanitary toilets that don't require water, and all the various things that they're doing. Is that a very worthwhile impact that they've had? And also, I'd like your comments on the organization of Doctors Without Borders.
Well, so you know, the Gates Foundation and other, the Gates Foundation is really, I think, making amazing, impactful work. And like any foundation, they have their priorities. So their priorities right now are on this major disease entities like, the big buckets like malaria and HIV/AIDS and the TB. Those kind of things are the biggest challenges they want to resolve. Can we get a vaccine for malaria, or can we find ways to detect and treat tuberculosis, which is actually a huge problem. So they have really huge goals. So when it comes to surgery, we have not advocated for surgery for a long time. And so, unfortunately, there is this gap in understanding that what we do is actually part of the healthcare system. In fact, there is no hospital or facility in the US that works well when you don't have surgeons. But that concept has not yet translated into works, into policies, and people don't understand that surgery is actually part of the public health that we should promote. And so that's partly because we have not been there to advocate for it, we're just getting there. So that's the only agency that provides some support has been, from surgery perspective, to some degree, the Fogarty Center, the Fogarty International Center for Fellowships. These are also really more on, you have a research question you want to resolve. So by going to global health work, that's really limited. From infrastructure perspective, we just got actually through USAID $700,000 this past week for infrastructure development at this training center that we have been supporting for the last 2 years. But this is going to be not for salary, it's not going to be for any training, it is infrastructure. So we want to make the operating rooms operational. We want to buy some equipment like water reservoirs and pumps so that we can have, we can scrub whenever we, with water. So those kind of things. So USAID has that kind of a program, and we were just awarded through USAID. Otherwise, Gates Foundation is really on the maternal part of things. They can go as far as supporting when it comes to C-section related work. So which is a backdoor entry for surgeons. And the OBGYN physicians have been probably 30 years ahead of general surgeons in general, or surgeons in general, in terms of getting into this field. So they have been much more lucky in getting some support from Gates Foundation. But I think we'll get there, because through the movement that we are having from the global surgical community now, we are making a lot of noise, and we are participating actually also on the global health advocacy effort that is happening also at the Capitol Hill. Because USAID can assign, just like they assigned $15 billion for HIV/AIDS, we have asked $100 million for surgical diseases, just to focus on trauma, for example. And so there is a lot more advocacy to be done. So if you know some strong senators that you can bring us to in the appropriation committee, that would be great, because it will help. That's what we have to do. Yes, sir.
Karma, fantastic work as always. I wonder, you and I have talked a lot about the
just was opening the slide just to show you one thing that, because of time, I didn't really go into depth, but what you said, Rebecca, is really important because it is not only the priorities of the individual, departments, but it's the priority of the country. So which means you have to pull in the policymakers. Otherwise, the sustainability is going to be a problem. So for this work in Hawassa, for example, the Ministry of Health was part of this team in creating the goals together, to a point where everybody that you see here has, so to say, skin in the game, right? And say the Hawassa University provided guest houses, lodging, and local transportation. That was their responsibility. And the Ministry of Health provided actually support for international travel. They paid 24 tickets a year for people to travel. And it was not a small amount, but they could afford it, but that was how important it was for them. And in fact, the same formula is going to be applied for the Zambia partnership, where the Ministry of Health, they're willing to do that. And the same with Rwanda. So they are all willing to do this as long as we are showing them that we are going to work actually based on their priorities and also trying to put their infrastructure together. And so this shared responsibility model was really a critical piece for everybody. And you can see my part from Operation Giving Back is there, and the U.S. surgical departments have also their roles. And it's interesting, for example, the Medical College of Wisconsin, they brought in some additional grants from their institution as well, like I did from Wisconsin through the Waldman grant, to really add value even more to what we do. And so it is so interesting when you look at the U.S. surgical programs, what we in kind contributed in 1 year was actually over $1 million. With equipment, with people's time, and so on and so forth. So when you bring those values, policymakers look at this, and actually they're all in.
Well, thank you.
Thank you.